Assalamu alaikum everyone and good evening. So we meet again after 1 week. Last week we started our discussion on the oral examination of the final prof medicine with respiratory system. So we could not complete all the topics that are usually asked in the oral examination. We talked about uh, tuberculosis, pneumonia, bronchiectasis, lung abscess, and pleural effusion. But still, there are a few important topics that were not covered in the last class. So we had to extend our respiratory class. So we again uh, conduct the class the same way we did previously, because in the exam the examination usually starts with an X-ray or ECG. So it is likely that your respiratory questions will come out of the ECGs you are asked to read out. Besides, there are some data which may be supplied or may be asked. So we start with an ECG, and this is our first case today. Just look at the ECG. This is the ECG. I think everybody can guess what the ECG of. That is, this ECG shows the lung fields are darker. So this is called a hypertranslucent lung field. So both the lung fields here are hypertranslucent. And look at the ribs. Ribs are quite horizontal than normal, and gaps between the ribs, that is, are bigger. So the ribs are widely spaced. And if you look at the lower part, that is the diaphragm, in both sides, the diaphragm is lower down, and the rounded contour, the semicircular contour of the diaphragm is somehow flattened. So this is called a low flat diaphragm. Finally, if you look at the heart is narrow than normal. So this is called a tubular heart. So if you have to read out the ECG, just like all the ECGs start with, this is an X-ray chest, sorry, the X-ray, this is an X-ray chest, posterior anterior view showing hypertranslucent lung fields, low flat diaphragm, then widely spaced ribs or widening of the intercostal spaces, and finally tubular heart shadow. So this is a typical X-ray, chest X-ray of chronic obstructive pulmonary disease or COPD. Okay, so the diagnosis will be COPD. Uh, don't forget to remember that other points which are not very important in this particular case should be mentioned as normal. So this is a X-ray chest of COPD. So COPD is one of the two types of obstructive airway diseases. You will be asked after you diagnose it as COPD that what are the obstructive airway diseases. So there are two obstructive airway diseases, COPD and bronchial asthma. So then you will be asked, that is, what is the basic difference between COPD and bronchial asthma? As both are obstructive airway disease, so what is the basic difference? The basic difference is the airflow obstruction, that is the reversibility of the airflow obstruction. In bronchial asthma, this airflow obstruction is reversible, and in COPD, it is relatively irreversible, not absolutely, but relatively irreversible. So the reversibility of the obstruction is less in COPD and it is more in bronchial asthma. But for exam purpose, you can straight say, to make it very simple, that is, in bronchial asthma, the bronchial obstruction is reversible. In COPD, it is not reversible. So how can you establish this difference? That is, in bronchial asthma, the obstruction is reversible. In COPD, it is not reversible. In fact, we can distinguish this difference. We can establish this difference with the help of a test, which is called spirometry and reversibility test. So what actually done in spirometry? From your, so you may be asked next, if examiner wishes, you may be asked, okay, then explain how this particular test will help you differentiating asthma and COPD. So spirometry actually were taught way back in phase 1 in physiology as lung function tests. So there were so many parameters there, but practically we use usually two parameters. One is forced expiratory volume in first second, or FEV1, and another one is forced vital capacity, that is FVC. So these two parameters are mainly used to define and classify obstructive airway diseases in practical situations. Uh, First step, we establish that this is an obstructive airway disease. So we do it with the help of a ratio that is called FEV1 FVC ratio. So if the ratio is less than 0.7, it indicates obstructive airway disease. So in spirometry test, the first step is to establish the obstructive airway disease. So when you have established the obstructive airway disease, then the next step is the reversibility test, where we will differentiate whether this is reversible or whether it is irreversible. So the next step is the second step, or the reversibility test. And it is the particular step that differentiates asthma and COPD by assessing the reversibility. So how it is done? It is done by measuring the FEV1 uh, before and after nebulizing the patient with salbutamol. We usually nebulize for 20 minutes. So what we do, we measure the FEV1 of the patient, then nebulize the patient for 20 minutes with salbutamol, and then again after that we measure the FEV1. So now we compare the previous FEV1 with the new one. So if there is an increase in FEV1, that is improvement of FEV1 by at least 15%, or not or, and 200 ml. So both these two criteria must be met. That is, FEV1 should increase by 15% and at least 200 ml. Then we call it a reversible condition, reversible airway disease. So this is a bronchial asthma. Very simple. And if this criteria is not fulfilled, that is, the improvement is less than 15% or less than 200 ml, it indicates irreversible airway obstruction or COPD. So just look at this. To be bronchial asthma, the improvement should be 15% and 200 ml. So both these two criteria must be fulfilled. And for COPD, if any of these two criteria is not fulfilled, then it is irreversible or COPD. Okay, fine. So again, with the link of COPD, you may be asked, what are the types of COPD? Very common question in oral exam. So there are two types, that is chronic bronchitis and emphysema. But if you mention this second line I have written here, that is, but in practical situations, these two types coexist. Actually, pure chronic bronchitis and pure emphysema are extremely rare. So in COPD patients, you will have both the features of chronic bronchitis and emphysema. So if you mention it, then the examiner will be very happy. Then you may also be asked about, okay, what is chronic bronchitis? Just look at it. In chronic bronchitis, the definition actually is a clinical definition. That it has a clinical link. There is productive cough for total 3 months a year in 2 consecutive years. That means uh, to define COPD, you have to wait 2 years. That is, the history should be of 2 years, and in every of these 2 years, there should be at least total 3 months of productive cough. So the cough with expectoration, cough with sputum production, it may not be continuously 3 months. It may be 1 month, then half month, then 2 months, like that. But total in 1 year, there should be 3 months history of productive cough, not dry cough. Another thing is this history should uh, occur in 2 consecutive years. Okay, this is chronic bronchitis definition. On the other hand, emphysema is not a clinically defined condition. It is a pathological condition, actually. Okay. So it means that permanent dilatation of the air spaces distal to terminal bronchioles with destruction of their of the alveolar walls without fibrosis. So what happens? That means the small airways, that is the alveoli and the previous few larger airways, that means all the airways that are distal to the terminal bronchiole are affected in emphysema. What is the affection? They are dilated, their walls are destroyed, but there is no obvious fibrosis of the wall. So this is the definition. So there is no clinical touch in this definition. So this is some kind of weird, that is the two types of COPD are described, but these two definitions are not comparable, because one definition, that is the chronic bronchitis one, is the clinical definition. It describes in terms of symptoms of the patient. On the other hand, emphysema is a pathological definition. It has no relation with the symptoms or signs of the patient. Rather, it is the histopathological finding in a COPD patients who described as emphysema. But still, they are asked, and you have to tell. So let's go into a case now. That is our next case. This is a clinical scenario. A 55-year-old man gives history of cough and dyspnea for 10 years. He's a smoker for 35 years. Clinical examination reveals vesicular breath sound with prolonged expiration. So what is the likely diagnosis? What investigations you want to do, and how to treat the patient? So this is an overall scenario type question given often in the oral examination. Just look at this. This is elderly person, and there is long history of smoking. So elderly person, long history of smoking, when presents with dyspnea, the likely diagnosis should be COPD. And here look at the duration, it's 10 years. So definitely the COPD is the diagnosis. Another thing is there is an important sign, that is vesicular breath sound with prolonged expiration. This is a sign of obstructive airway disease. So this sign is present in both asthma and COPD. So uh, when there is an obstructive airway disease and long history of smoking, and the person is an old one with dyspnea, then the diagnosis should always indicate a COPD. Okay. Uh, so this is a COPD case. So what investigations you want to do? Just the previous thing, that is, first of all, you have to do an X-ray. It will show all the features of COPD, like low flat diaphragm, hypertranslucent lung fields, tubular heart shadow, widely spaced uh, ribs. Another interesting finding is presence of emphysematous bulla. Although this finding is very uncommon, but still it is an important finding. But the most crucial investigation is spirometric investigation, that is a spirometric reproducibility test. Okay, so you will be asked, so what you expect in spirometry? You will have to answer the same way as as we have discussed already. That is, in spirometry, first of all, we will define it as an obstructive airway disease with the help of FEV, FEV1 FVC ratio. Then we will do the reversibility test, and of course, with the parameters indicates irreversible, we call it COPD, just like that. There is a improvement of FEV1 less than 15% or less than 200 ml indicates COPD. Okay. So the third question was how to treat the patient. First of all, the first step in treating the patient is to stop smoking. This is the best way to actually slow down the progression of the disease. So COPD is largely an irreversible disease. You cannot cure it completely, but still, if you can withdraw the main culprit that caused it, the progression will be shortened. So, and then you have to give some drugs. So regular basis, there are some inhaled drugs which are given, like long-acting anticholinergics. Example is tiotropium, long-acting beta agonists like salmeterol, and inhaled steroids. So all three these groups are inhaled drugs, like fluticasone. And these drugs can be given isolated or in combination according to the severity of the disease, according to the response of the patient. So these drugs should be taken on a regular basis. And when the patient develops troublesome symptoms, then you have to give the patient short-acting inhaled agents, short-acting beta agonists like salbutamol, or short-acting anticholinergics like ipratropium. Again, they can be used isolated or in combination. So I haven't mentioned another thing, that in COPD patients there is a very good mode of treatment, that is long-term domiciliary oxygen therapy. So at home, most of the COPD patients has hypoxia. So to correct it at home, you can give 1 to 2 liters of oxygen at least 12 hours a day continuously. It improves the lung function, it improves the symptoms, and it gives the patient a good relief with a better outcome. So I haven't mentioned it here, but please remember, okay? So three things in the management of COPD. Number one is stop smoking. Number two is some drugs, and these are preferably inhaled drugs. And finally, uh, long-term, low-dose, low-flow oxygen therapy. So three things. Okay. And then you may be asked that can you mention a few oral medications used in COPD? Of course, there are a few oral medications like xanthine derivatives, and the currently choice of such group is doxycycline, and phosphodiesterase 4 inhibitor, that is roflumilast. So these two agents can also be used if required in COPD patients, but these are oral agents. But it is always preferable to use the inhaled agents, because inhaled agents directly act on the respiratory system with the minimum side effects. So what are the complications of COPD? The main complication of COPD is acute exacerbation of COPD. Usually when a COPD patient gets an infection, respiratory tract infection, commonly a bacterial respiratory infection, the uh, condition deteriorates. That is, the COPD itself worsens. This is called acute exacerbation of COPD, and it leads to type 2 respiratory failure. And it also leads to respiratory acidosis. What happens, we will discuss type 2 respiratory failure later. In type 2 respiratory failure, there is low oxygen, that is hypoxia, and high carbon dioxide, that is hypercapnia. As carbon dioxide is acidic, so it will cause acidosis. So this kind of acidosis is called respiratory acidosis. This is also a complication of COPD. In fact, in any condition that cause type 2 respiratory failure will cause respiratory acidosis in addition, because of the increase of carbon dioxide in blood. Uh, Another complication is cor pulmonale. So what is cor pulmonale? Cor pulmonale is a condition of heart. In fact, it is a disease of the right ventricle. So what is the condition? In fact, this is the hypertrophy of the right ventricle with or without failure. So the key thing is hypertrophy of right ventricle. So there may or may not be failure. So hypertrophy of right ventricle secondary to primary disease of the respiratory system is called cor pulmonale. So there is a disease of the lungs that causes hypertrophy of the right ventricle of the heart. This is called cor pulmonale. So this is different from right heart failure secondary to left heart failure, or right ventricular hypertrophy secondary to left heart disease. This is different. It is right ventricular hypertrophy secondary to lung disease. And the most common cause of cor pulmonale is COPD. Another important cause, although less common than COPD, is interstitial lung diseases. So we'll have a short look on interstitial lung diseases at the very end of today's class. So let's drop this interstitial lung disease for the time being, because we have more important things to discuss now. Okay. So then you may be asked, so if someone with COPD develops a cor pulmonale, what signs will expect? So what is cor pulmonale? It is right ventricular hypertrophy in a uh, lung disease patient. So in a COPD patient, there will be signs of COPD, but in addition, there will be signs of right ventricular hypertrophy. In addition, there will be signs of right ventricular failure if it is present. So right ventricular hypertrophy signs will be definitely there. Plus, there may be signs of right ventricular failure. So what are the definitive signs of cor pulmonale? These are signs of right ventricular hypertrophy, the two important signs, that is left parasternal heave and epigastric pulsation. And if the patient has failure, I have already said not all core pulmonary patient will have failure, right ventricular failure. All will have right ventricular hypertrophy, but some will have right ventricular failure. So those who have right ventricular failure will also have the signs of right ventricular failure. So three cardinal signs will be raised jugular venous pressure, tender hepatomegaly, and dependent edema. So if you are asked that what are the additional signs you may find in a patient of core pulmonale, uh, that you will say that I will find the sign of right ventricular hypertrophy, and I may also find the sign of right ventricular failure. So then you will be asked, so what are the signs of right ventricular hypertrophy? These are epigastric pulsation and left parasternal heave. What are the signs of right ventricular failure? There are three cardinal signs: raised JVP, tender hepatomegaly, and dependent edema. So we have another case now. There is a very elderly person, 70-year-old man, was brought to the emergency. So it is an emergency condition with sudden severe dyspnea. He had cyanosis, vesicular breath sound with prolonged expiration, and rhonchi. So what is the likely diagnosis? What investigation you will do, and what is the emergency management? Just look at this. It is an elderly person, and this person has dyspnea. So there could be quite a few causes, but in the last line, I have already said that there is vesicular breath sound with prolonged expiration and bronchitis. These are signs of obstructive airway disease. So this man has an obstructive airway disease, and as this is an elderly person, the likely obstructive airway disease is COPD, not asthma. And so this is a case of COPD, but the dyspnea is so severe, the patient had to come to the hospital emergency. So this is a case of acute exacerbation of COPD. So what investigation you will do? Uh, the investigation will be arterial blood gas and chest X-ray. So remember, in acute exacerbation of COPD as well as in acute exacerbation of asthma, we will not go for spirometry because patients will be so dyspneic, they will not be able to perform the spirometric maneuvers. So the other tests will be helpful. What we expect in arterial blood gas? In fact, we expect the features of type 2 respiratory failure. That is low oxygen, high carbon dioxide, and low pH. We will discuss respiratory failure a few minutes later. So let's get into the next question. That is, how will you manage the patient? We will manage the patient with immediate oxygen inhalation, but remember we have to give low flow oxygen and then nebulize the patient with salbutamol and ipratropium. We have to start prednisolone and have to continue it for a few days. Usually COPD exacerbations are associated with bacterial respiratory infections, so a broad spectrum antibiotic should also be given. And if all these measures fail to improve the patient, then you have to send the patient to ICU for uh, artificial ventilation. So this is the basic step. That is low flow oxygen, nebulization with salbutamol and ipratropium, prednisolone, broad spectrum antibiotic, and in case of refractory cases, there will be need for artificial ventilation and ICU referral. So you may be asked in such if we have used low flow oxygen. So the patient is cyanosed, patient needs oxygen, but still you cannot give high flow oxygen. Why? The answer is a bit critical because in COPD patients there is long-standing hypoxia and hypercapnia. In brain, we have a respiratory center in the brainstem, and this center is driven by two stimuli. One is hypoxic stimuli, and another one is hypercapnic stimuli. Usually in COPD patients, because of long-standing hypercapnia, the hypercapnic stimuli is lost. The hypercapnic drive is lost. So it is only the hypoxic drive that keeps the respiratory center moving, running, so breathing can continue. So if you correct the hypoxia very rapidly with high flow oxygen, then the respiratory drive, the hypoxic respiratory drive may get off and the respiratory center will stop functioning spontaneously. That may lead to total arrest of respiration. So you can answer like that. That is, the brainstem respiratory center is driven by hypoxic and hypercapnic drives. In COPD, the hypercapnic drive is not working. The only working drive is the hypoxic drive. So if we correct hypoxia with high flow oxygen very rapidly, then the respiratory center will stop working and then lead to respiratory arrest. So that is why we cannot use high flow oxygen in COPD patients. So another case, that is a 25-year-old lady attended the outpatient. So this is not an emergency case with recurrent shortness of breath since her childhood. The symptoms are worse at night. The clinical examination reveals vesicular breath sound with prolonged expiration. Again, uh, an obstructive airway disease as evidenced by vesicular breath sound with prolonged expiration. And it is in a young lady who has never smoked. So the likely uh, cause will be bronchial asthma. Okay. So how will you confirm this case? With the help of spirometry, of course. Okay. So why this is bronchial asthma? In this scenario, we have quite a few information that actually indicates bronchial asthma. One is childhood onset. Then obviously the patient actually mm, has severe symptoms at night. So these 2 points actually indicate bronchial asthma. How we'll discuss shortly. This is bronchial asthma because dyspnea and vesicular breath sound with prolonged expiration suggest obstructive disease. And childhood onset and diurnal variation, that is worse at night, indicates bronchial asthma. So definitely, without the help of spirometry, we can still guess whether this is asthma or COPD. So there will be a few points we are discussing. Obviously, when you are asked how to confirm this is asthma or COPD, the answer will be spirometry and reversibility test, just like before. But if you are asked, okay, you don't have spirometry facility, can you now guess or clinically identify bronchial asthma or COPD? Yes, it is still possible uh, with the help of few symptoms and the help of few signs. So in bronchial asthma, there are 5 clinical points in history that are suggestive of bronchial asthma. That is, one is childhood onset of symptoms, diurnal variation. The asthma symptoms are usually worse at night. Seasonal variation, it will vary, but in the most cases, the asthma symptoms are worse during winter season. And worsening of symptoms on exposure to dust or smoke. Finally, asthma is an allergic condition. So if the patient has allergic conditions like allergic conjunctivitis, allergic rhinitis, or eczema, then this condition is likely to be bronchial asthma. So presence of any of these 5 conditions usually indicate bronchial asthma. On the other hand, uh, there are a few signs that are present in COPD. So these are not symptoms. For COPD, we have 5 signs, and presence of any of these 5 signs indicates COPD. Just like pursed lip breathing, barrel chest, tracheal tug, impalpable apex beat, and low down liver dullness. So, presence of any of these 5 signs indicates that the underlying condition is probably COPD, not bronchial asthma. So, what is common in COPD and bronchial asthma? Uh, both has dyspnea, both has cough, both have same findings in the auscultation of chest. There is vesicular breath sound with prolonged expiration and bronchi. But still, if someone has any of these 5 clinical points in history, it is asthma. If someone has any of these 5 signs, it is COPD. So if there is a mixture of these signs and symptoms, then what is the condition? Okay, such condition we call it asthma COPD overlap syndrome. ACOS, asthma COPD overlap syndrome. Now, how to treat bronchial asthma? First of all, the first advice will be to avoid dust and smoke. Not only dust and smoke, anything that exacerbates the symptoms. It may be a particular situation, particular animals, particular things within the room like carpets or anything like that. The patient should know it, that what situations make the symptoms worse, and mm, the patient should avoid such things. In occupational areas, there are some occupational related allergens and that may worsen the symptoms. The patient should change the occupation or try to avoid this as much as possible, or may use ventilators to reduce the exposure. And of course, there are some anti-asthma medications. Uh, there are different groups of anti-asthma medications which are used according to the severity of the disease. So what are the anti-asthma medications? Asthma medications are two types. One is relievers and another one is preventers. So relievers are very short-acting drugs. They are usually inhaled beta agonist and inhaled anticholinergics, and they are used when there is troublesome symptom. Okay. So relievers are inhaled drugs. Commonly in asthma, we do not use short-acting anticholinergics. Short-acting beta agonists are usually used, and the drug is salbutamol. So when we will use the preventers, when the attacks are frequent, the troublesome episodes are frequent, that is more than or equal to 2 per week, then we have to use the preventers to reduce the frequency of attacks. Again, the preventer drugs are different types. There are either inhaled drugs, there are oral drugs, and inhaled agents are always preferred. So, two inhaled agents that are usually preferred in preventing asthma episodes are long-acting beta agonist, that is formoterol, and long and inhaled corticosteroid, that is budesonide. So these two drugs are now the drugs of choice for preventing asthma episodes. Still, we have oral agents acting as preventers in asthma. These are leukotriene antagonists. The agent is montelukast. This is a very popular drug in our country. And xanthine derivative doxycycline, which we can also use in COPD, is also helpful in preventing asthma episodes. So these oral drugs can also be used in addition to the inhaled agents, but still the inhaled agents are preferred. Let's get into another case. That is a 20-year lady rushed into the emergency with sudden severe dyspnea. She never smoked. She had cyanosis and bronchitis. So look at this. This is another case. This is an emergency case, and on this happened to a young lady. The patient had dyspnea, and there was bronchitis. So when there is bronchitis, it is either COPD or asthma. As there is no smoking history and the person is very young, 20 years, it is likely to be asthma. So what kind of asthma? It is a case of acute severe asthma, because it forced the patient to come into the emergency to get relief. The patient couldn't wait at home. So this is a case of acute severe asthma. What investigation to be done is arterial blood gas. And arterial blood gas shows type 1 respiratory failure. And what is the emergency management? Actually, the emergency management is high flow oxygen. So here is no hypercapnia in bronchial asthma. So both the hypoxic and hypercapnic are intact. So you can use high flow oxygen to correct the hypoxia, and the respiratory centers will continue working with the hypercapnic drive. So no problem with using high flow oxygen in severe asthma. Next, you have to give inhaled salbutamol and ipratropium with the help of a nebulizer. Again, prednisolone is given, uh, and artificial ventilation can be used when these measures fail to improve the condition. Just see, we do not use usually do not routinely use antibiotics in severe acute asthma. We used antibiotics in acute exacerbation of COPD. Apart from this antibiotic, there is not much difference. Yes, of course, there is a difference in the flow of oxygen, but other things are almost equal. That is nebulization, prednisolone, and artificial ventilation. So why? Because asthma attacks are usually precipitated by viral respiratory infections. So asthma patients indiscriminately should not be given antibiotics with severe attacks. So this is the answer. That is, acute severe asthma is treated with high flow oxygen, nebulization with salbutamol and ipratropium, prednisolone. And when these measures fail to control the symptom or improve the symptom, then you have to go for ICU admission and artificial ventilation. So you may be asked, so what are the overall causes of sudden severe dyspnea? If a patient comes to the emergency uh, to you with very severe shortness of breath, what are the possibilities? So there are six possibilities commonly. One is severe acute asthma, acute exacerbation of COPD, acute heart failure, tension pneumothorax, massive pulmonary embolism, and psychogenic hyperventilation syndrome. So these six are the common causes when someone comes to the emergency with severe shortness of breath. So we have used the term respiratory failure, type 1 respiratory failure, type 2 respiratory failure while we were discussing COPD and asthma. So what actually is meant by these two terms, type 1 respiratory failure and type 2 respiratory failure. So the main function of respiration is exchange of gases. That is, it brings oxygen from environment into the body and it removes carbon dioxide from body into the environment. So when these gaseous exchange is not adequate, it is called a respiratory failure. So in respiratory failure, one thing is common, that is hypoxia. So when there is hypoxia but no hypercapnia, this is type 1 respiratory failure. And when there is hypoxia plus there is hypercapnia, it is type 2 respiratory failure. So type 1 respiratory failure is caused by conditions. Uh, okay, you will be asked. So respiratory failure is usually diagnosed with the help of arterial blood gas analysis. So what are the changes in arterial blood gas in type 1 respiratory failure? I have already said this is hypoxia but no hypercapnia. So as there is no hypercapnia, there is no acidosis. So the pH will be normal. So in arterial blood gas, the partial pressure of oxygen is not low. The partial pressure of carbon dioxide will be normal. It means hypoxia without hypercapnia. And as there is no hypercapnia, that is no high carbon dioxide, there is no acidosis, so the pH of blood will be normal. Again, you will be asked, what is the sign of type 1 respiratory failure? The only sign of type 1 respiratory failure is central cyanosis. In fact, what is the common sign of all types of respiratory failure? The common sign of all types of respiratory failure is central cyanosis. Central cyanosis means hypoxia. So what are the common causes of type 1 respiratory failure? The common causes of type 1 respiratory failure again can be described as acute and chronic. Acute type 1 respiratory failure occurs commonly in acute severe asthma and acute heart failure. So these two are the most common cause. It can also cause in pneumonia and ARDS. But if you just tell acute severe asthma, acute heart failure, pneumonia, that's fine for the final cause. And chronic type 1 respiratory failure occurs in bronchial asthma, not the acute ones. Chronic heart failure, interstitial lung diseases, cyanotic heart diseases like tetralogy of Fallot, and GSD, ASD, PTA after shunt reversal. And of course, oxygen is mainly carried out by hemoglobin. So severe anemia patients may also have hypoxia. So severe anemia can also cause chronic type 1 respiratory failure. So respiratory failure type 1 is characterized by cyanosis. In ABG, you will have low partial pressure of oxygen, but normal partial pressure of carbon dioxide and normal pH. The cause in it can be acute, like acute severe asthma, acute heart failure, pneumonia. It can be chronic, like bronchial asthma, chronic heart failure, interstitial lung disease, cyanotic heart disease, and severe anemia. So I have already said type 2 respiratory failure means hypoxia with hypercapnia. So in arterial blood gas, you will find low partial of oxygen, high carbon dioxide, this is hypercapnia, and because of high carbon dioxide, there will be acidosis, which is called respiratory acidosis. And because of this acidosis, the pH of blood will be low. So what is the ABG finding of type 2 respiratory failure? The finding is low PO2, high PCO2, and low pH. So it can be assumed that in respiratory failure type 2, there is often respiratory acidosis. So what are the signs of type 2 respiratory failure if you are asked by any chance? Of course, because all respiratory failure will have cyanosis, there will be also central cyanosis. But in addition, there will be signs of hypercapnia. So there are actually three signs of hypercapnia. Please remember these three signs. I have written it in the slides. The three signs of hypercapnia be there in type 2 respiratory failure. These are warm periphery, then bounding pulse, and flapping tremor. So warm periphery, bounding pulse, and tremor. Warm periphery means the pulse, it will be warm. Bounding pulse means high volume pulse. And flapping tremor, it is a type of tremor. It occurs in different conditions like hepatic encephalopathy, encephalopathy, and also in type 2 respiratory failure. These three signs are signs of hypercapnia. As in type 2 respiratory failure, we have both hypoxia and hypercapnia. We will have signs of hypoxia and hypercapnia. Hypoxia is central cyanosis, signs of hypercapnia are three, and pulse and flapping tremor. So in type 2 respiratory failure, we will have central cyanosis, bounding pulse, and flapping tremor. So again, what are the causes of type 2 respiratory failure? We will have acute and chronic. Type 2 respiratory failure actually caused by overall COPD and any condition that causes paralysis of the respiratory muscles. Okay. So in fact, acute type 2 respiratory failure occurs in the acute form of complication of COPD, that is acute exacerbation of COPD, and some neuromuscular conditions which presents acutely, like Guillain-Barré syndrome, myasthenic crisis, poisonous snake bite, I should rather say venomous snake bite, and then certain poisons that cause neuromuscular paralysis, like organophosphorus poisoning, opioid poisoning, and benzodiazepine poisoning. In fact, opioid and benzodiazepine poisoning actually depress the respiratory centers, and organophosphorus and carbamide poisoning, they cause dysfunction of the neuromuscular junction. So mechanism is different, but the end result is the same. That is weakness of the respiratory muscles. And chronic type 2 respiratory failure occurs in COPD and motor neuron disease. Again, in motor neuron disease, you will have a chronic weakness, long-standing weakness of the muscles. So that includes the diaphragm and other respiratory muscles. So it may lead to chronic type 2 respiratory failure. So the next case is an X-ray. So it shows, this is an X-ray chest. Okay, it shows, just compare the two sides. In the left side, everything is fine, but if you just carefully look at the right side, there is an area in the outer portion. This area, this area has no vascular markings. In fact, this area has no lung tissue. And if you see carefully, the area medial to has it is area has features of lungs. It has vascular markings. So in fact, this is an hypertranslucent area devoid of vascular markings. So this is actually air. Okay. So this is hypertranslucent area in the all zones of the right lung field with collapsed right lung medially. So this is a case of pneumothorax. Carefully see the trachea is slightly shifted to the left. So it is compressing, this air is compressing the right from the right side. That is why the trachea is shifted to the left. So your diagnosis should be right-sided pneumothorax. So what type of pneumothorax it is? Actually, before that, we have to uh, discuss the types of pneumothorax. In fact, pneumothorax are of three types: closed pneumothorax, open pneumothorax, and tension pneumothorax. So in closed pneumothorax, what actually happens in pneumothorax, a pleural cavity is devoid of air. So how the air gets into it? In fact, there should be a communication between the pleural cavity and the airways, or there should be a communication between the pleural cavity and the outside. Uh, in both the conditions, if this communication is closed after some air gets into the pleural cavity, uh, it is called a closed pneumothorax. So there will be air in the pleural cavity, but this air volume is fixed because some air got into it. Now the communication has ceased and the communication does not persist, so no new air will get into it. So the volume of air within the pleural cavity is fixed. This is called a closed pneumothorax. On the other hand, if the communication persists between the airways and the pleural cavity, uh, the air will get into the pleural cavity during inspiration and it will get out of the pleural cavity during expiration. So this is called an open pneumothorax. There is a third type, that is there is a communication persisting between the airways and the pleural cavity, but the communication is one way. So not like the open pneumothorax in which the air can get in and get out. Here the air can only get into the pleural cavity, but it cannot get out of it. So there will be progressive increase in the volume of air in the pleural cavity. So the increasing volume of air in the pleural cavity will compress the lungs, then it will compress the mediastinum. So this is very dangerous. This is called a tension pneumothorax. If we just compare these three conditions in closed type, okay, we have air here, but there is no communication, it will fix. In open type, there is a communication, so air gets in and then gets out. It's not much dangerous. But in tension type, the air can only get in, it cannot get out of the pleural cavity. So the progressively the volume of air in the pleural cavity increases. It causes the compression. So this is a very dangerous condition, and it will cause shifting of the mediastinum. So in our case, there is actually shifting of the trachea to the left, and the pneumothorax is in the right. So this is a tension pneumothorax. Okay. So why this is a tension pneumothorax? Uh, because the trachea is shifted to the opposite side. So how the symptom of this patient? In fact, the main symptom of tension pneumothorax is chest pain and severe dyspnea. I have already said what are the causes of sudden severe dyspnea. So apart from the other causes like severe acute asthma, acute exacerbation of COPD, acute heart failure, we mentioned tension pneumothorax. So this is one case. This tension pneumothorax. What sign you will get? In fact, if you examine the patient, the examine the chest of the patient, you will find the following signs. There is on inspection, obviously the movement will be restricted on the affected side. Here, the movement will be restricted on the right side. The trachea already shown in the X-ray. That is, trachea will be shifted to the opposite side, so the trachea will be shifted to the left. The expansion of the chest will be reduced, and the vocal fremitus will be absent in the right side. On percussion, the percussion note will be hyper resonant. So it is opposite of that of other unilateral lung conditions. In pleural effusion, in consolidation, we had dull, but here it is hyper resonant. And the breath sound and vocal resonance are absent. So pneumothorax and pleural effusions have some similarities. Uh, Everything is absent or reduced in both the conditions. And but the difference is the percussion. That is, in percussion, in pleural effusion, uh, the percussion note will be dull, and in pneumothorax, the percussion note will be hyperresonant. What are the causes of pneumothorax? So pneumothorax can be traumatic, can be non-traumatic. In medicine, we are more concerned about the non-traumatic pneumothoraxes, which we call spontaneous pneumothorax. And spontaneous pneumothorax is caused mainly by primary pneumothorax, that is, there is no apparent underlying lung disease. This is the most common cause of spontaneous pneumothorax. But there are a few lung diseases which may cause pneumothorax. So when there is an underlying lung disease and a pneumothorax, we call it a secondary pneumothorax. The most common one is COPD. COPD patients often have pneumothorax, but bronchial carcinoma and lung abscess can also produce pneumothorax. So pneumothorax secondary to COPD, bronchial carcinoma, or lung abscess is called secondary pneumothorax. But in the majority of spontaneous pneumothorax cases, the cause is not apparent. There is no clean-cut underlying lung disease that can be linked. So these are primary pneumothorax. Besides these spontaneous pneumothorax, there are traumatic pneumothorax that can happen, like any form of chest trauma, in thoracoscopy or thoracic surgery. Even it can occur when we try to aspirate pleural fluid. We can accidentally uh, get air into the pleural cavity if we don't take the measures carefully. And finally, artificial ventilations of, if done too much, often cause pneumothorax. So these are traumatic ones. So we have already discussed the types. So now, how will you treat our case? In fact, in tension pneumothorax, the treatment is emergency needle aspiration. You have to insert a needle in the upper part of the chest, and so the some air will get out and reduce the pressure within the pleural cavity. And it should be followed by water seal drainage. So the management of tension pneumothorax is immediate intercostal needle aspiration followed by under water seal drainage. Open pneumothorax cases are usually treated by surgical correction. Closed pneumothorax cases are usually not treated with any active intervention. Most of the cases, only follow-up is good enough. The air entrapped is fixed, so it will get absorbed over days. But if a closed pneumothorax is very big and causing troublesome symptoms, then you can also perform water seal drainage for very big closed pneumothorax. But in our case, this case was tension pneumothorax. The management is immediate. You have to save the life of the patient by inserting a needle in the upper part of the chest, that is intercostal needle aspiration and percutaneous needle aspiration of air, followed by water drainage. So this is another case. In this X-ray chest, there is a opacity in the left lung field. It is in the middle zone of the left lung field, and it is near the hilum of the lung. If you look carefully, this lesion has an irregular border. irregular corrugated border. So this is the typical X-ray of bronchial carcinoma. So this is an X-ray chest posterior view showing an non-homogeneous opacity. The opacity is the homogeneous, non-homogeneous opacity in the mid-zone of the left lung field with irregular border, and the opacity is near the high lung. So describe other things as normal, that is costophrenic, cardiophrenic angles are intact, trachea central, there is no bone elation, the soft tissues are normal. So this is a case of bronchial carcinoma. So what could be the presentation of such an X-ray? The presentation is a long history, not much long, history of few weeks to few months of coughs, hemoptysis, chest pain, and weight loss. So fever is very unusual. Fever is very unusual in such patients. So what signs you look in this patient in general examination? This is often a tricky question. That is, there are a few signs found in general examination in bronchial carcinoma patients. These are the patient, because of the weight loss, the patient is cachectic. There will be anemia, there will be clubbing, and there may be cervical lymphadenopathy. Supraclavicular is the most common site for lymphadenopathy. So how will you investigate? What further test you want to do? Of course, you will do a CBC with ESR. If the patient has sputum, then you can test the sputum for malignant cells. This is called cytology. And the most important test here will be bronchoscopy with biopsy. So as the lesion looks quite central, that is near the larger airways, central part of the lungs, the bronchoscope will be accessible, and you can see the lesion directly with the help of bronchoscope. You can take biopsy for histopathological examination, because carcinoma is diagnosed with the help of histopathology. So this is the most definitive test in this patient. That is, if you are asked which is the most important test, the answer will be bronchoscopy with biopsy. And the bronchoscopy with biopsy will ultimately define the diagnosis. So how will you treat the patient? Okay, this is not entirely your job. And the treatment, there are different modalities of treatment. There can be surgery, there can be radiotherapy, there can be chemotherapy. So any combination of these can be used. So it will depend on the type of bronchial carcinoma, on the stage of bronchial carcinoma, and it is better decided by a team that includes the surgeon, the physician, and the oncologist. So this combined team will decide which modes of treatment will be used. So you better answer such smartly. That is, there are quite a few modes of treatment like surgery, radiotherapy, and chemotherapy. And which mode or modes will be used will be determined combinedly by the physician, by the surgeon, and the oncologist. You don't have to remember the exact name of the chemotherapy agents. So what are the histological types of bronchial carcinoma? There are four types. This squamous cell carcinoma, adenocarcinoma, small cell carcinoma, and large cell carcinoma. So among these four, the worst one is the small cell carcinoma. You may be asked, that is, which type is the worst? That is, the worst is the small cell carcinoma, because small cell carcinoma metastasize very early. Another important question is, what are the paraneoplastic syndromes in bronchial carcinoma? So before that, you should know what is paraneoplastic syndrome. In fact, paraneoplastic syndrome are symptom complexes. These are signs and symptoms that occur in tumor-bearing patients, which cannot be explained by the local or distant spread of the tumor. That means you cannot explain the symptoms of a tumor patient with invasion or metastasis. Neither you can explain the features with any hormonal activity originating from the uh, tissues from which the tumor arises. So this is the in basic, that is, there will be some symptoms which cannot be explained by the direct structural damage by the tumor, that is invasion or metastasis, or by any hormonal activity which the tumor originating cell secretes. Okay. So these are paraneoplastic syndromes. The common paraneoplastic syndromes in bronchial carcinoma are endocrine ones, and the most common two are syndrome of inappropriate ADH secretion that causes hyponatremia and hypercalcemia. These two are the most common, but uh, bronchial carcinoma may also cause Cushing syndrome by releasing ACTH-like substance. Okay. So the bronchial carcinoma cells, when they are anaplastic, they change their function, they change their structure. They can produce hormone-like substances. They can produce ADH-like substance causing fear. They can produce parathormone-like substance causing hypercalcemia. They can produce ACTH-like substance that cause Cushing syndrome. Another one is a neurological, that is Lambert-Eaton myasthenic syndrome. This is a neuromuscular junctional disorder uh, similar to myasthenia gravis. Another one is dermatomyositis and polymyositis. These are inflammatory myopathies often associated with bronchial carcinoma. And finally, hypertrophic osteoarthropathy. This is a painful lesion in the distal parts of the limbs, affect the distal parts of the bones of the limbs. Uh, Besides, clubbing is a very common paraneoplastic condition associated with bronchial carcinoma. So if you are asked which is the most common paraneoplastic syndrome of bronchial carcinoma, it should be clubbing. Then mention these five. We go into another case. This is like the previous one. There is an opacity in the mid zone and partly lower zone of the right lung field with non-homogeneous texture. It has an irregular margin and it is also near the right high lung. But in addition, if you look carefully, there is elevation of the right hemidiaphragm. Look at the left hemidiaphragm and now compare. The right one is quite high up. This is called elevated right hemidiaphragm. So this is also a case of bronchial carcinoma. So you have to explain why the hemidiaphragm is raised here. You will be asked why. So the answer will be this is possibly due to invasion of the right phrenic nerve and paralysis of the right hemidiaphragm. So this tumor, this bronchial carcinoma has invaded the right phrenic nerve, and because of the damage to the right phrenic nerve which supplies the the right hemidiaphragm is paralyzed, so it is high up. Normally, the diaphragm, when it contracts, it goes down, and when it is relaxed, it goes up. So here it is always relaxed, so it is high up. So the explanation is this uh, raised right hemidiaphragm, elevated right hemidiaphragm is phrenic nerve palsy due to tumor invasion. We have another case here. It's a chest posterior anterior view showing apparently homogeneous opacity in the apical region, the upper zone of the right lung. So we cannot make a straightforward diagnosis from this X-ray. We have three differential diagnoses in such a condition. So these are, it could be a case of pulmonary tuberculosis, it could be a case of consolidation, it could be a case of Pancoast tumor. Pancoast tumor is a bronchial carcinoma that occurs in the apex of the lung. Pancoast tumor is nothing but a bronchial carcinoma located at the apex of the lung. So what other investigation you want to do? Just like any differential of TB, pneumonia, and carcinoma, you can do complete blood count with ESR. You can go for sputum test. But here, the most definitive test will be CT guided FNS. Why I am telling you? Because this lesion is quite far from the larger airways. It is quite peripheral lesion. So the airways here will be very narrow. So the bronchoscope will not be able to reach this area. So if you want to get some tissue from here, the only way you can get it through the needle, and the percutaneous needle aspiration. Okay, you can get needle through the skin into the lesion directly. It's better to do it under CT scan guided, because see the lesion directly with the help of CT scan, and then get the needle in directly into the peg position, and take sample through the needle, and uh, examine the sample for malignant cells or some other things. So this FNAC, CT guided FNAC, is the most useful test in such lesions, okay, peripheral lesions. So how do FNAC will help? In fact, if in FNAC, if you find malignant cells, it is Pancoast tumor, no doubt. And if you find granulomatous lesion with caseous necrosis, it is diagnosed as tuberculosis. Caseous necrosis occurs only in tuberculosis. So if you get caseous necrosis, it is tuberculosis. And if you get granuloma but no caseous necrosis, then still tuberculosis is the most common possibility. So, how CBC can be helpful as before? If it is high ESR, it is either tuberculosis or malignancy. If polymorphonuclear leukocytosis, it is consolidation. So just like previous uh, conditions when you have three differentials, TB, pneumonia, and malignancy. So CBC helps in the same way. Yeah. So what is Pancoast tumor? Pancoast tumor is a bronchial carcinoma located at the apex of the lung. So there are two unique features, clinical features of Pancoast tumor. You may be asked, so what are the very unique features when the tumor, the bronchial carcinoma, is located at the top of the lung? These are Horner syndrome and wasting of hand. So what is Horner syndrome? Horner syndrome is a combination of ptosis, meiosis, that means constricted pupil, enophthalmos, that is small eye, and anhidrosis, that is lack of sweat. So these four, like this picture, is the normal eye. Just look at the abnormal one. The eyelid is went down, gone down. That is ptosis. The pupil is small. This is meiosis, and the eye looks smaller. This is enophthalmos. So I cannot tell about the sweating here. So these four are the features of Horner syndrome, and one of the most common cause of Horner syndrome is Pancoast tumor. It occurs when the tumor invades the cervical sympathetic chain. Cervical sympathetic chain supplies the pupils, the eyes. So that is why, because of this abnormality uh, in the eye, the parasympathetic nerve gets an upper hand. So you know the parasympathetic nerve uh, constricts the pupil. So here the pupils will be constricted. Again, some involuntary muscles in the upper lid are present, which are supplied by the sympathetic nerve. So those muscles will be inactive. So there will be ptosis and meiosis. Again, you will be asked, so why there is hand wasting in Pancoast tumor? As the apex of the lung is quite close to the brachial plexus, in fact, the lower part of the brachial plexus, the tumor may invade the lower part of the brachial plexus. So the lower part of brachial plexus usually supplies the muscles of the hand. So because the nerves supplying the muscles of the hands are damaged because of tumor invasion, there will be wasting of the hand. Okay, these are the explanations. We will go into another case, that is here. Just look at this X-ray. There is a round opacity in the upper zone of the right lung. Everything else is normal. Just ignore this change. Yeah. So if you find such single round opacity in the X-ray, it is called a solitary pulmonary nodule. And solitary pulmonary nodule is commonly due to bronchial carcinoma. But still, there are a few conditions which may also produce such nodules. So among them, important conditions are benign lung tumors like adenoma, consolidation, tuberculosis, even fungal infection of the lungs can also produce such conditions. So how will you diagnose? Which most important investigation will help you in diagnosis? Again, just like Pancoast tumor, the most important investigation in such a solitary pulmonary nodule is CT guided FNSC. It will directly collect the tissue, and histological and microbiological examination of such tissue will bring out the definitive cause. So what is the most important investigation in such solitary pulmonary nodule? The most important investigation will be CT guided FNSC. So I'm not going to get into the detail. It is just like a pancreas tumor. So here another X-ray. Here we see there are quite a few rounded lesions, both in the right sides, more in the left sides, and these are scattered over all zones of both lung fields. So when there are multiple rounded lesions in lung fields, the diagnosis is lung metastasis. That means malignancy somewhere else, which has spread to the lung by metastasis. So this is the case of pulmonary metastasis. So you will be asked, name a few primary tumors that commonly metastasize into lung. So any tumor can metastasize into lung, any malignant tumor, but the most common ones are colorectal carcinoma, renal cell carcinoma, thyroid malignancies, and breast carcinoma. These four metastasize most in the lungs. So another X-ray, it is similar to the previous one. Here the number of rounded lesions is more. So there are numerous rounded lesions of variable sizes scattered over both lung fields. The trachea is central, heart shadow normal, bony thorax, and the soft shadows are normal, postophrenic, cardiophrenic angles are intact. So this diagnosis is pulmonary metastasis. Another important question is, if someone has such an X-ray, so what is the outcome of this patient? Overall, the outcome is very poor because pulmonary metastasis indicates advanced disease in any kind of malignancy. So the overall prognosis is very poor. Yes, so you may be asked, what is the outcome? What is the prognosis of this case? The answer will be, the prognosis is very poor because pulmonary metastasis indicates advanced malignancy. Look at this beautiful. Okay. So here there is a non-homogeneous opacity in the entire left lung field. Apart from this, the trachea is also shifted to the left, the heart is also shifted to the left. So when an lesion in the lung causes shifting of the trachea or the heart or the both towards it, it is either fibrosis or collapse. Okay, either fibrosis or collapse. In collapse, the opacity is relatively homogeneous. Here it is not absolutely homogeneous, but relatively homogeneous. So this is probably a case of collapse of the left lung. So what is the cause of collapse? Now, common cause of collapse. The commonest cause of collapse is bronchial carcinoma, but collapse can also be caused by lymphoma and foreign body infection in the bronchial tree. So this is collapse of the left lung. What is the cause? The most common cause could be bronchial carcinoma. So how does it cause collapse? The carcinoma occludes a very big bronchus. So airways distal to it ultimately collapses because of the lack of air. How lymphoma can cause collapse? Lymphoma can cause mediastinal lymphadenopathy, hilar lymphadenopathy. So those large lymph nodes can compress the bronchi from outside, causing obstruction of the lumen. So the same way, there will be no air entry into the lateral bronchial tree, which will collapse. However, foreign body can cause collapse. A foreign body can occlude the lumen, causing cessation of air entry into the distal bronchial tree, causing collapse. So it is very, very reasonable. The most common cause is bronchial carcinoma. So what is the most important investigation to find the cause of collapse? The investigation will always be bronchoscopy and if needed with biopsy. So what symptom the patient may present with? So with such large involvement of one lung, symptom is obviously shortness of breath. So you may also be asked what signs you expect in collapse. In fact, the signs of collapse is the same as the signs of pleural effusion, except in pleural effusion, the trachea is either central or pushed towards the opposite side. But in collapse, as it draws everything towards it, the trachea will be shifted to the side of lesion. So when you examine a patient with left-sided collapse, there will be uh, in the left side, there will be reduced chest movement, there will be reduced chest expansion, there will be absent vocal fremitus, the trachea will be shifted to the left, percussion, there will be dullness and auscultation, the breath sound and the vocal fremitus will be, vocal resonance will be absent. So I have already discussed the causes and the investigation. This is another case. Here there is a lesion in the lower zone of the left lung field, and it has also caused the shifting of the trachea and the heart towards it. So this is also a case of collapse, but the collapse here is obviously it is a collapse of the left lung, but the entire left lung is not collapsed here. So you will be asked whether the entire left lung is collapsed. Answer will be no. So then what? It could be middle lobe collapse, it could be lower lobe collapse, but to confirm it, it appears to be a lower lobe collapse, but to confirm which lobe has collapsed, you have to go for a left lateral view X-ray. Okay, so we need to do an X-ray chest, left lateral view to confirm which lobe of the left lung has collapsed. So this is the last X-ray. In fact, this X-ray is a bit complicated. Just look at it. We have changes in both sides. First of all, there are patchy opacities in the left side, also in the right side. But in addition to these patchy opacities, there is a non-homogeneous big opacity in the right upper part. That is the right upper zone and the mid zone. It should also be noted that the trachea and the heart are drawn towards the right side. So there is something which is pulling the mediastinum, the trachea and the heart towards it. So I have already said it is either collapse or fibrosis that cause such changes. Here, the opacity is non-homogeneous. In collapse, the opacity is more or less homogeneous. So this is a case of right-sided fibrosis, fibrosis of the right lung. Plus, as there are patchy opacities in both sides, so there is pulmonary tuberculosis. In fact, bilateral pulmonary tuberculosis with fibrosis of the right lung. So this is the diagnosis. So the main hallmark is fibrosis of the right lung. Fibrosis is commonly caused by when it is localized fibrosis, that is the left lung is not affected by the fibrosis, the lower part of the right lung is not affected by the fibrosis, only a part of the right lung is affected. This is called a localized fibrosis. So such localized fibrosis of lung is usually caused by tuberculosis. But there are other two important causes of such localized lung fibrosis. These are lung abscess and bronchiectasis. So lung abscess and bronchiectasis, apart from pulmonary tuberculosis, can cause localized fibrosis. So if you examine this patient, what sign you may find? In fact, you may find the signs that are quite similar to consolidation. But the difference is in consolidation, the trachea is always central. But here, the trachea will be shifted towards the lesion. That means if you examine this patient, uh, you will find the following things in the right side. That is, on inspection, the movement will be restricted. On palpation, the chest expansion will be reduced. The trachea will be shifted towards the right. The vocal fremitus will be increased, just like consolidation. There will be dullness on the right lung. And on auscultation, the breath sound will be bronchial. The vocal resonance will be increased. So these are the features of localized fibrosis of lung. So this is the cause. This tuberculosis is responsible for majority of the cases of lung fibrosis, localized lung fibrosis. Other two important causes are lung abscess and bronchiectasis. You may then also be asked, so if these are causes of localized lung fibrosis, is there any generalized lung fibrosis? This is called diffuse lung fibrosis. Yes, there are a group of diseases that cause diffuse lung fibrosis, and these group of diseases are called interstitial lung diseases. So these interstitial lung diseases, there will be diffuse fibrosis of both the lungs, usually symmetrically. And in interstitial lung diseases, you will not get the typical features of localized lung fibrosis. The only sign of diffuse lung fibrosis or interstitial lung disease is bilateral crepitations. And symptom is usually dyspnea. Such interstitial lung diseases, you should know of name of a few important interstitial lung diseases, and you may be asked, so name a few interstitial lung diseases. You may not know the detail of these ILDs, but at least you should know the names. You may be asked. So these are the common interstitial lung diseases. One is pneumoconiosis or occupational lung diseases. That is interstitial lung disease that occurs due to occupational exposure of different substances like silicosis, asbestosis, this coal workers pneumoconiosis. So these as a group are called pneumoconiosis or occupational lung diseases. Next one is idiopathic pulmonary fibrosis, then sarcoidosis, connective tissue associated interstitial lung diseases, and drug-induced interstitial lung diseases. So you may be asked which connective tissues are associated with interstitial lung diseases. Many connective tissues diseases can cause interstitial lung diseases. The most common one that cause interstitial lung disease is systemic sclerosis. Besides, SLE and rheumatoid arthritis can also cause interstitial lung diseases. These are multi-system disorders. They can involve different organs, multiple organs of the body. So they can also involve the lung, causing fibrosis diffusely involving both the lungs. So you may also be asked, can you mention any drug that can cause interstitial lung disease? Yes, the drugs we use commonly, methotrexate can cause interstitial lung disease. So you can only recall the name methotrexate. There are some anti-cancer drugs like bleomycin, then busulfan. They can also cause, but they are not commonly used. The commonly used drug in medicine, that is methotrexate, that has wide range of uses, particularly in chronic inflammatory arthritic conditions like rheumatoid arthritis, uh, then seronegative psoriatic arthritis, or juvenile idiopathic arthritis. We use methotrexate. So this methotrexate may cause interstitial lung disease. Just if you mention methotrexate as a drug that causes ILD, it's fine enough. So I think it is quite late. This lecture went quite long. I hope that with this lecture we have ended the common oral questions for final Prof MBBS examinations on respiratory system. So still there may be a few questions I haven't discussed. So I will ask if you have any query regarding any final Prof question. Please write it in the comment. I will try to answer as early as possible. So with this, I wish you all the best. We will meet again soon, probably with the discussion on cardiovascular system questions on final profs, hopefully next week. So till then, you guys care. Allah Hafiz. And thank you for such patient listeners. Thanks a lot.